The name of this opioid analgesic is Alfenta, or generically alfentanil hydrochloride. Alfenta is supplied in 2, 5, 10, or 20 milliliter vials, with each milliliter containing 500 micrograms of Alfenta. Alfenta works like other opioid drugs by attaching to opioid receptors. Alfenta has a nearly exclusive affinity for mu receptors at normal clinical doses. When Alfenta attaches to a mu opioid receptor, it activates a GI-coupled protein. This leads to many effects, including an efflux of potassium, lowering the resting membrane potential and hyperpolarizing the cell. There is also an inhibition of voltage-gated calcium channels, leading to reduced influx of calcium into the cell. Adenyl cyclase is also inhibited, leading to a reduced production of cyclic AMP, and therefore reduced activation of cyclic AMP-dependent cellular processes. These actions result in decreased cellular activity and, most importantly, decreased neuronal transmission. During normal pain transmission, an action potential comes up the afferent pain fiber, causing an influx of calcium, which releases glutamate, glycine, and substance P. The glutamate and glycine activate an AMPA and NMDA receptor, causing potassium to efflux and sodium to influx, causing the interior of the postsynaptic cell to become more positive, eventually releasing the magnesium from the NMDA receptor, allowing calcium to come in, activate a protein kinase C, which activates a nitric oxide synthetase, releasing nitric oxide up into the presynaptic cleft. This releases more glutamate and glycine into the cleft, causing further pain and possible windup. When an opioid agonist is administered, it activates a mu receptor presynaptically and postsynaptically. This causes potassium channels to open and potassium to efflux. This causes a hyperpolarization of the cell, leading to inactivation of inward rectifying voltage-gated calcium channels, the AMPA and NMDA channels, leading to decreased pain transmission. Alfenta is only given intravenously. In a spontaneously breathing patient or a patient requiring minimal ventilation assistance, the induction dose for analgesia is 8 to 20 micrograms per kilogram, followed by a maintenance dose for analgesia of 3 to 5 micrograms per kilogram every 5 to 20 minutes, or 0.5 to 1 micrograms per kilogram per minute, not exceeding a total dose of 8 to 40 micrograms per kilogram. For a patient requiring frequent assistance or controlled ventilation, you can provide dosing by either incremental injection or continuous infusion, and you can give doses to cause anesthetic induction. Doses using incremental injection for induction of analgesia are 20 to 50 micrograms per kilogram, with maintenance of analgesia doses of 5 to 15 micrograms per kilogram every 5 to 20 minutes, not exceeding a total dose of 75 micrograms per kilogram. Doses using continuous infusion for induction of analgesia are 50 to 75 micrograms per kilogram, with a maintenance of analgesia at doses of 0.5 to 3 micrograms per kilogram per minute. To induce an anesthetic state, an induction dose of 130 to 245 micrograms per kilogram is needed, with a maintenance dose of 0.5 to 1.5 micrograms per kilogram per minute, administered with general anesthetic. The onset of Alfenta is roughly 90 seconds due to its pKa of 6.5, meaning that almost 90% of the drug is in the non-ionized form at physiological pH, making it very easy for it to cross the blood-brain barrier and have its effect. Alfenta reaches peak levels in the brain and plasma in 1 to 2 minutes. The T-half alpha, or plasma half-life of Alfenta, is from 10 to 15 minutes, which means that its analgesic effects start to be subtherapeutic in 50% of the people at that time. The T-half beta of Alfenta is 84 minutes to 120 minutes, which means that plasma levels decrease by half in that time. The context-sensitive half-time for Alfenta after at least a 4-hour infusion is 60 minutes. The clearance of Alfenta is 238 milliliters per minute, with a terminal elimination half-life of 475 minutes. The major uses of Alfenta are related to its very short time of onset and its short duration of action. It's ideally suited to blunt the response of noxious stimuli that is short in duration, such as things like direct laryngoscopy or prior to incision for surgery. Some anesthetic concerns for Alfenta include adjusting the dose for extremes of age, in which we mean you want to give more for younger people with higher metabolic metabolic function and less for older people with less. Also, you'd like to adjust it for higher BMIs, giving slightly more as it's very lipophilic. If a patient is on erythromycin or cimetidine, it's going to decrease the clearance of Alfenta, increasing the duration of action. If your patient has hepatic or renal impairment, it will also affect the metabolism, increasing the duration of action. You want to use extreme caution in administering Alfenta in patients who have a head injury or respiratory depression, as with all opioid agonists, it blunts the respiratory drive in the brain. Here are 3 interesting links for Alfenta that you can look at the World Wide Web.